Okay, we'll get started. Hello, everybody. Welcome to the Patterns of Practice in Relapsed Multiple Myeloma webinar. I will just go through some housekeeping notes first. Thank you for attending the webinar. This meeting is being recorded. All attendees have been placed on mute with cameras disabled. Please submit your questions while a QA function on Zoom, which is distinct from the chat function. These will be addressed during the question and answer panel discussion. Please use the chat function on Zoom to communicate any technical difficulties, and please take a few minutes to provide feedback via the survey at the end of the webinar. Thank you. So go ahead and get through with some introductions now. So we'll have first 20 minutes, just a little bit of an introduction to the platform, My Cancer Haven, and then we will talk about a few questions, polling questions. Thereafter, I'll hand it to my colleague, Joshua Richter, for talking about navigating early multiple myeloma relapse. We'll have a panel discussion. Do send in your questions for that. And then Dr. Zonder will talk about triple class refractory myeloma. We'll have another panel session, and then we will wrap up. So first, to introduce my colleagues and esteemed panel members here, Dr. Jeffrey Zonder is Professor of Medicine in the Department of Oncology at the Karmanos Cancer Institute at Wayne State University in Detroit, Michigan. Welcome, Jeff.
Thank you.
And then we have Dr. Joshua Richter, who's Associate Professor of Medicine at the Tisch Cancer Institute and Director of Myeloma, the Blavtic Myeloma Family Chelsea Medical Center at Mount Sinai School of Medicine, New York.
Thanks for having me.
Okay, so I will, as I said, just take a few minutes to just go over our platform. Several of you who have signed up for the webinar are probably aware of it, others may not. So the mission of My Cancer Haven is to connect. It is to connect patients, expert healthcare professionals, and organizations through a single patient-centric, custom-designed, curated, and moderated cloud-based platform. We have a number of features for security. The first time a patient or any healthcare provider, for that matter, creates an account, there is two-factor authentication. Thereafter, it is not needed. We have both a mobile and a web-based interface. We have what I like to call cancer type specific ecosystems. The effort started in myeloma in January this year. Since that time, we've grown to leukemia and lymphoma, and then more recently, MDS. I anticipate before the end of the year, myelofibrosis and amyloidosis to also be open for participation. In each of these ecosystems, it is self-contained information for each different kind of cancer. We have three main areas. One is access to the opinion of experts. We have a panel of physicians that we link to their websites so that patients can find in different areas of the United States true experts in the area of multiple myeloma. We are creating a library of videos. Some of these are basic videos, myeloma, which goes under the MCH 101 folder. We're also having updates on our conferences. We have clinical trials, some of the promising results from drugs in clinical trials, and we also link to resources that patients would find useful, other advocacy groups and not-for-profit organizations that have done a great job in helping patients and have unique offerings for patients. Patients also have the ability to submit a question to the platform, and we as administrators try to address that in one or more format. The second feature is a patient community. We have a set of blogs. These blogs are created by healthcare professionals, and patients are not at the moment able to blog, but they can certainly read the blogs and hopefully find information that is useful to them. We also curate a Twitter feed, again, from key opinion leaders, patient advocates, and advocacy organizations that tell patients about now new initiatives on a daily basis. We also have our own news aggregator, which is updated literally by the minute automatically. Anything with a keyword that is in that specific cancer type, you will get an updated news. We also have a feature where we can create groups. Any user can create a group and act as an administrator of group. We have some pre-existing groups to support patients. Patients can message one-on-one. Patients cannot message healthcare providers. There is a firewall in that direction, and also healthcare providers are not able to message patients. We also seek the patient's perspective by asking questions and have patients respond. And we also have polls. The last feature is a sanctuary, which is a private place, not visible to anybody else, where a patient can keep a journal and keep a calendar. All new content within a 7-week period is automatically updated in a automated email that goes out on Thursday morning with links directly to those specific blogs, videos, or other chats that a patient may be interested in that have been updated over the last 1 week. Also, every couple of weeks, we send out a little email called the MCH Digest, which tells patients about our new initiatives. So that was a brief introduction to the platform. Now we will just go through a series of, I believe, 5 questions. And Navya, you can go ahead and start the questions. So first question is your role. Are you a patient, a caregiver, or other? We're going to be capturing this information for our own purposes and won't be displaying any results. Okay, I think that may be captured by now. Can probably move on to the next question. Okay. Give it a second. Okay, Navi, are you able to move that forward?
Yes, which a few of them are answering.
Oh, there's still some answers awaited. Okay. I guess some of them may not be choosing to answer or may have stepped away, so we can probably go on to the next question. Okay. Are we having some technical issue there, Navya?
No, which?
So it hasn't changed the question.
No, I have changed. I have changed it to age. Second question.
Is it? Because on my screen, I'm still seeing the same question, but okay. So that's fine. All questions. Okay. Okay. I think you can go ahead because Josh and Jeff, are you seeing the same question?
I actually don't
I
see any
do.
question.
I don't
Okay,
either.
yes, you may not have, you have to go to polls and quizzes, but that's fine. So, okay,
Oh, yeah, I went to polls and quizzes, but I'm still seeing the first question.
okay. So Navya, if you are able to advance it, otherwise we can skip the poll.
Yeah, I have launched the fourth question as well, which
Okay, but maybe it is visible to the patients only because I can't, it seems the panelists are just seeing the first question still. Okay. And so Navya, you're on which question now? Which answers have you captured?
so I'm on fourth question, which
Okay,
what is
and
a useful resource for cancer journey?
okay, that's fine. So okay, I think we're having some technical difficulty because one of the patients has actually said that there are no questions showing. So we'll skip this and we'll go on to our what you call main presentation. So it gives me great pleasure here now to have Dr. Joshua Richter from Mount Sinai talk to us about navigating early multiple myeloma relapse, which regimen is right for you. This webinar is a little more advanced. It is not a myeloma 101, but there's a lot of myeloma 101 information on the platform for those who wish. So this is more of an advanced course, so as to speak. So take it away, Josh.
Thank you so much, Ravi, and thank you to everyone taking time out of their Saturday to join us on this amazing platform, My Cancer Haven. Next slide, please. So I'm going to walk through the latest and greatest of how we think about early relapse myeloma, and this is a really important concept because I think this is where we make some of our biggest impacts. Just some general demographics. You know, we still recognize myeloma as the second most common blood cancer, but myeloma, we're number one. And this is really because the lymphoma docs, they cheat. They have diffuse large B, CLL, follicular. We have one disease. We're really number one. There are about 35,000 new cases. And because the death rate of myeloma continues to drop every year, we have a steadily increasing number of people living with myeloma in the United States. You know, we look back to textbooks when I was in medical school, and it was, you know, not that much fewer new diagnoses, but because the survival was much shorter, there are only around 40 to 60,000 people in the US living with the disease. Now, again, even this data is old, we're probably up to over 150 to 175,000. The average age is around 69, and it does increase with age, but unfortunately, myeloma can afflict people of all ages, and we do have a number of patients, even in their 20s, 30s, and 40s. And overall, it does represent just under 2% of all cancer. Next slide, please. So we really have improved things dramatically. And, you know, when we look back, and some of this data is maintained on a website called the SEER website, where the government maintains general statistics about cancer survival over the years. And you look back to the 1970s and the 1980s, where we really had very few tools, and the tools that we had were not very effective. The entire journey of myeloma from diagnosis to death, all comers, was around 2 years. Overall survival. And the reality is we don't know how long a patient diagnosed with myeloma in 2023 will live because we have no 5-year survival data. In fact, we only have 5-year survival data up to 2017 because the 2018 5-year survival data still hasn't come to fruition. But you see these numbers rising and rising and rising, and there's a number of reasons why they're rising. One of them is just we have better therapies. So people are doing better. But the other thing is that we've really evolved from giving classical chemotherapy, drugs that were invented around World War II and short time after, which just, you know, indiscriminately kill cells dividing, to more targeted therapies that have better efficacy and better tolerability. As a result, we're able to combine drugs in ways that are much more tolerable. So in the old days, when you would combine 2, 3, or 4 chemotherapy drugs, although your response rates go up, you're adding a lot in terms of toxicity. With many of our modern day therapies in myeloma, we're able to combine 2, 3, 4 drugs, sometimes even more, in a relatively tolerable fashion. And it's the synergy of all these drugs that can kill more of the myeloma, lead to deeper remissions, and ultimately better outcomes. And, this is accelerating. If you look at the number of drugs approved in the last decade, this is the list here that we have from 2014 and beyond. This is rising every year. There'll likely be another one or two approvals next year as well. So the sky's the limit. Next slide, please. Now, ultimately, even though the approach that we use, the specific drugs and the dosage and the combinations, that changes every year, but the general approach to newly diagnosed myeloma has not changed much in the last 40 years. And the idea of when we diagnose a patient with myeloma, our first pass is, are we going to proceed towards an autologous stem cell transplant or not? There are no hard and fast rules in the United States. In general, people who we deem transplant eligible tend to be younger and fitter. People who we deem transplant ineligible, we tend to call them older or frailer. But again, I've done autologous transplant on people well until their 80s because age is just a number. Once we diagnose patients and we feel that they need treatment, we give them some type of initial therapy that we call induction. This usually lasts anywhere from 3 to 4 cycles. Sometimes we need more. I've had patients have 6 cycles or more if need be. For the patients who go into transplant, we collect stem cells, move forward with the high dose treatment and the stem cell transplant, and almost everyone ends up in the same bucket of having continual or maintenance therapy. And unfortunately, at the moment, many patients end up in the group of relapsed disease, and that's what we really want to focus on today. Next slide, please. So when it comes to relapse, there are really two different facets of relapse that we like to think about. One is a clinical relapse, and one is a biochemical relapse. And let me start with the biochemical one. And all the biochemical, and actually I have a better way of calling it. So in these two relapses, I term this, I tell you you're relapsing, or you tell me. The I tell you you're relapsing is the biochemical one. That's where you come in to see your care team. You're feeling completely fine, but your levels of the myeloma proteins are creeping up. Your M spike has gone up by 0.5 gram. Your light chains have gone up by 100. Your urine protein has gone up. You feel fine, but the doctor or the nurse or the MP says, listen, your myeloma has come up. We need to shift gears. That's a biochemical relapse. The other one, the clinical relapse, is where you tell me. This is where you come into clinic and say, I'm feeling more fatigued. I notice some bone pain. I just feel off. When people have symptoms, and this is really harkens back to the classical crab symptoms of myeloma, hypercalcemia, renal insufficiency, anemia, bone lesions, that's a clinical relapse. And this is very helpful because this kind of figures out how quickly do we need to get you back into remission? Do we have time to give you a regimen that may be a little better tolerated, but may take several months to get us where we need to go? Or do we have to get this right now the first time because maybe your kidneys are having problems? Next slide, please. So when we decide what we're going to do for the next treatment, there isn't a clear-cut guideline. In fact, one of the main references for how to treat myeloma, the NCCN guidelines, lists options in alphabetical order to not show preference. So the reason why it's very important to be seen at a myeloma center like Dr. Vijay's, Dr. Zonder's, my own, or many of the others that can be found through websites like My Cancer Haven, is that the way we approach it, it's not clear-cut for everyone. Everyone has a unique journey, and we use 3 main factors to decide your next course of therapy: patient-related factors, disease-related factors, and treatment-related factors. So patient-related, are you older or younger, fitter or frailer? What comorbidities and what medications are you taking? Disease-related factors, is the disease growing fast or slow? Is this a biochemical or a clinical relapse? Do you have extramedullary disease, a massive myeloma that's pressing on an organ that needs to be dealt with? And ultimately, the first pass that a lot of us use is treatment-related factors. What therapies have you had before? What have you not had before? So what are you naive to? What have you had but stopped working, meaning refractory or resistant to? What have you had but maybe you stopped before transplant and you're still sensitive to that drug? And which drugs did well or not? If I put you on drug A and you did not so well with it, I may not use the second generation of drug A. I may do what we call class switching to use a different mechanism of action. Next slide, please. So ultimately, when we look at patients in early relapse, for many years, patients went into their early relapse. And again, for early relapse, we're defining as 1 to 3 prior lines of therapy. Late relapse is typically denoted as 4 or more. For many years, patients would enter early relapse still either naive to lenalidomide or Revlimid or sensitive, meaning they got something like RVD up front and a transplant and then no maintenance, or they went on RVD, stayed on Revlimid for a while and at some point stopped it and are now relapsing still sensitive to lenalidomide. And here we see some of our best data to date. And all of these are phase 3 studies comparing Revlimid and lenalidomide and dexamethasone versus a triplet, lenalidomide and dexamethasone plus either carfilzomib, ixazomib, elotuzumab, or daratumumab. And ultimately, these therapies, there's no clear answer for everyone, but one of the things we've begun to understand is that CD38 antibodies, drugs like daratumumab and isatuximab, are absolutely critical in early relapse. If you enter early relapse either naive or sensitive to them, these are going to be some of your best options. So if we look here, we look at Eloquent and Tourmaline, we get around 20-month median PFS. Aspire had 26.3 months. And Pollux, even though it says not evaluable, when the study finally did read out, it was 44.6 months. So again, almost a doubling of the median PFS for some of these regimens if we're bringing in an anti-CD38 drug like daratumumab or isatuximab. Next slide, please. Now, what has evolved over the last number of years is that a lot of people in the United States are lenalidomide refractory going into their early relapse, either doing something like induction therapy, transplant, and Revlimid maintenance, and then progressing on Revlimid, or some of the older, frailer patients getting what we would call VRD light, and then stopping the Velcade, staying on Revlimid, and then progressing. So we started to have to look for regimens that would work in patients who were no longer responding to Revlimid. And here we see some of the data for patients who are refractory to Revlimid, and this is a pomalidomide-based regimen, pomalidomide being the next generation drug of Revlimid. And here we compare with the PomDex control arm, which only gave us around 5 to 6 months, but we're improving this data to over a year with some of the therapies, including the anti-CD38s like isatuximab PomDex and daratumumab PomDex. Next slide, please. So, when we're starting to figure out what drug is going to be the right backbone, again, we go back to treatment-related issues. And there are a lot of people who go on to lenalidomide as a maintenance therapy. And if you look at some of the data, many patients will stay in remission for years and years and years, and that's the absolute best. I love seeing my patients on Revlimid once every 3 months. We chat about what they're doing in their lives and their kids, and I say, great, I'll see you in 3 months. And that's many people. Unfortunately, some people will not have that duration of remission on Revlimid, and the Revlimid as a class of agents, the IMiDs, won't work as well as we want. And for those patients, we like to class switch, or oftentimes may class switch in that early relapse, and instead of giving a pomalidomide-based regimen, we may switch over to a regimen that's based off of a proteasome inhibitor. And these are drugs like ixazomib, bortezomib, and carfilzomib. So here we see some of the studies that we looked at in early relapse, comparing against a bortezomib or Velcade-based control arm. And these are the top ones. And we see a variety of different therapies. And a few things that really pop out of this. One is that in general, the median survival, progression-free survival, remember this is how long you're staying in remission, not how long you live, are generally around a year. Interestingly enough, in myeloma, we always talk about triplets over doublets, But something that has always been quite interesting is that the Endeavor trial, carfilzomib dexamethasone, actually had better progression-free survival than many of the triplets in this setting. So there are still scenarios where we will only give 2 drugs instead of 3. Now, one of the things that's mentioned here is the Panorama study. Panabinostat is unfortunately no longer available in the US. It was taken off label because of lack of a sufficient confirmatory phase 3 study. So that's not available. And the combination of selinexor, bortezomib, and dexamethasone is a really interesting regimen where traditionally we think of selinexor being a later line therapy. But to me, there's actually a very important group of patients who will benefit from this combination in early relapse. If you look across the last 15 years, most patients receive Velcade as part of their upfront therapy, but don't progress on it. However, over the last 5 years, with the rise of using regimens like daratumumab, Revendex upfront, we have a new generation of patients who are entering early relapse, naive to proteasome inhibitors, refractory to CD38 and refractory to IMiD. So if you go on Dara-Revdex up front and you have a shortened response to it, whereas the average response is likely to be over 5 years, and you're entering that phase refractory to an IMiD, refractory to a CD38, but naive to a PI, and definitely naive to a drug like selinexor, to me, I think that regimen holds an important place in that setting. Alternatively, we have seen that some of the most effective regimens, the highest response rates, have been the carfilzomib-based studies, and this is what we see with the IKEMA and the CANDOR study. Now, again, this slide is, the data has been updated, and if you look at the median progression-free survival, the CANDOR regimen is around the low 30 months. Progression-free survival, IKEMA, depending upon which data cut you look at, is somewhere between 35 and 41. But overall, the CD38 carfilzomib-based regimens in early relapse have shown us some of the best data. Next slide, please. And again, the SVD regimen, or Boston, this was a head-to-head of selinexor Velcade Dex versus Velcade Dex, a regimen that was looked at in 1 to 3 prior lines. And in the US, we generally reserve selinexor for a later relapse, the triple-class refractory patients that Dr. Zonder will talk about shortly. However, again, someone who doesn't get those 5 years or more from Dara, Rev, and Dex up front, I do think there's a role for this, of providing not only a PI like bortezomib, but another mechanism of action. And we have a limited number of new agents in that setting, so you can add cyclophosphamide, which is what's called an alkylator, although not a day goes by where we don't find out that alkylators may not be the best drugs to use in myeloma because of some of their side effects. Now, that doesn't mean we can't use them. We use them all the time as a means to an end. The question is there something better? And that's where I do feel that selinexor Velcade Dex would have a great role. The important thing here is the selinexor needs to be given once a week and with appropriate prophylaxis to minimize side effects. Next slide, please. So here are NCCN guidelines about what to do in early relapse. And again, it's 1 to 3 prior lines. And we look over the lenalidomide refractory because these are really the majority of patients that we see entering early relapse. Bortezomib refractory is less common in the US. But one of the most important things to see on the right is that in the NCCN guidelines, unless otherwise specified, the NCCN recommends the regimens as a class 2A. You can see that there's a number of regimens that are classified as category 1, and almost all of them include a CD38 drug like isatuximab or daratumumab. So it's really important to start incorporating these drugs either as part of your upfront regimen or early relapse, or in some cases both. Next slide, please. So the conclusions are that the myeloma landscape is becoming more and more complex with lots of new drugs, lots of new regimens. In general, we use 3 drug combinations for early relapse. There are cases to use 2. But really the one advocacy thing I would throw out there is, the people on this call, Dr. Vij, Dr. Zonder, myself, have seen thousands and thousands of patients with myeloma. The average hematologist oncologist in the US may only see 0 to 10 a year. So now the one thing we have to thank for COVID is platforms like Zoom. So if you or a loved one is followed by an oncologist that's not at least consulting with a myeloma center like one of ours or one of the other ones in this country, I think there's a lot of advantage even to have those conversations so that we can then communicate with your local doctor to provide more optimal therapy. And with that, I'd like to thank Dr. Vij for hosting this and pass it back to him.
Thank you very much. So I guess we'll have Dr. Zonder's camera come back on. Okay, there he is. Okay, thanks, Josh, for that excellent overview. So I know we went through a menu of different regimens and table upon table, and I guess it is one of those things that even we as physicians sometimes start our head starts spinning about how do we actually incorporate one or more of these. So you said it best. I never heard it that way. That biochemical relapse is when you I tell you you're relapsing, and true relapse is when you tell me you're relapsing. So how do you approach these differently? If you do you have a one fits all strategy? I know you mentioned that you take into account various patient disease related factors, but how do you put it together?
Sure. So let's take the I tell you. For the I tell you, the biochemical relapse, I think a lot of times I end up giving a regimen like daratumumab, pomalidomide, and dexamethasone. And if you look at the data in the US, it's actually the most common. It makes up about 10 to 12% of prescriptions in this first relapse. And the wonderful thing about this one is that once you get 6 months into this, your daratumumab is just a once a month sub-Q injection, and the rest of it is oral, so it's balances high efficacy and great quality of life. Um, that being said, when patients have these really bad relapses, they show up with renal failure or giant lesions or something where they're in extremis, where we need to get a response immediately. We may not have the time to wait for the IMiD to show up. That has to go through the REMS program. So for patients that need response now, I typically give either daratumumab and Kyprolis or isatuximab and Kyprolis. These are more aggressive regimens. They require more visits back and forth. They're a little more durable. Um, Again, there's a lot more subtlety, but if I had to group it into two big categories, that's generally what I do.
So Jeff, what about yourself?
Well, at first, I agree with everything Josh just said, but I also wanted to point out that the timing to initiation of treatment in the I tell you relapse is highly variable. A lot of in a lot of situations, as long as you're keeping your eye on the ball, you can actually follow a patient who's had a gradual biochemical relapse for a period of time. And there's a variety of reasons why a patient may choose to do that. Um, Sometimes we have the sort of conversations about, like the common question is, what's the magic number? Like, what does my M protein or my light chain have to get to before we'll start treatment? And the answer is there isn't really necessarily a magic number. One of the slides Josh showed, uh, if there's a sudden surge of the rate at which the M protein is going up, that matters more. That pattern is actually more important than the absolute number. And so, we talk about that all the time. I mean, I think that when a biochemical relapse doesn't necessarily mean you need to launch back into treatment, but it should mean that the disease, that the patient and their myeloma gets a sort of a once over. For me, it's an automatic trigger for reimaging to make sure
Mhm.
that I know that it isn't really a you telling me situation and I'm just not listening or looking, right? And so I look at the bones, and stuff like so. Um, and then once we've reassured ourselves that it's really just biochemical, sometimes we'll follow for a period of time. Um, when a patient's when therapy is started for relapse that is still just biochemical, I agree that regimens with easier schedules or with a lesser side effect profile, or even a side effect profile that at least the patient's already familiar with, and so that there's a sense of like expectation about what they can anticipate. I think that that's what we tend to go with. Um, there's a big spectrum of practice, and I'm thinking about the various myeloma doctors I know in the New York area, Josh, and I know that there's a huge spectrum of practice just amongst your colleagues in New York about what happens when there's a biochemical relapse. I know a person who was started on a quad when they went out of MRD negativity, and
Yep.
right? I mean, and I also know patients who have an actual biochemical relapse and are just being followed, just
Hmm.
as well, which are kind of opposite. You can think of them almost as opposite responses to similar situations.
Yep.
Yeah.
I
So.
totally agree. I think that tells you about the art of medicine and how much ambiguity there still exists in the information on which we rely on practicing. Now, but there may be some specific situations where there may be a little more consensus. So, what about after patients get their first line treatment, I think we're often expecting both with transplant and non-transplant treatments, even these days, that their disease will be in control for 5+ years. But we all see patients, unfortunately, where the disease comes back sooner, sometimes within a year, year and a half. Is that an area where you would, Jeff, even without the disease being too symptomatic, consider early intervention?
I think first of all, early relapses are uncommon, but when they happen, it tends to be an aggressive course after that. There are some patient subgroups, certain high risk FISH or cytogenetic changes that sort of predict that's going to happen, and then there's this group of patients that uh, we as a myeloma community are really interested in right now, which are the functional high risk patients. Patients who you would have assumed would be average or better based on all the prognostic criteria we use, and then lo and behold, a year into their treatment, they're progressing, and that's a surprise when that happens, right? And when a patient has an early relapse or early progression, I actually do favor early initiation of like a quad type regimen if possible, at least a triplet. Um, the one regimen that wasn't, I think, shown or wasn't on the NCCN guidelines, uh, Dara, Pom, Car, Dex. Um, we that was recently published, and very, very effective regimen. And just in terms of if you're thinking about all the different possible combinations, uh, whether they're FDA approved combinations or not, um, the data for that regimen and our experience with that regimen has been really quite impressive.
So obviously, the more drugs you throw into the mix, the more likely that you're going to have a response, and more likely also that it will be somewhat longer lived. What about the other end of the spectrum, Josh, where you have, unfortunately, a lot of patients are in their late 80s, even in this disease, and they value some other things like convenience, as you mentioned, as one of the factors, or they have a difficult time coming to the doctor's office. There, someone has to take off work to get them there. So, what are some of the things that can be done in that situation?
Sure. So, I think several options. One is if we're able to negotiate or figure out the logistics to do the initial step up, not step up, but the initial weekly dosing of um, daratumumab, eventually we do get to a once a month. But that being said, some people can't even do that. So there are a number of all oral triplets that'll be very effective. Some of them are actually incorporating ixazomib that I know we generally don't use as much. But for someone who's refractory to Revlimid, you combining ixazomib, pomalidomide, and dexamethasone can be a very effective regimen. And another one that I think is really well tolerated is pomalidomide, cyclophosphamide, and dexamethasone, PCD. So, I think exactly as you're pointing out is myeloma is never going to be a one size fits all. So it's really nice that we have some of these other all oral options to make things easier.
So, what are the side effects that you're looking out for, Josh, in some of these regimens, these drugs? Obviously, there are so many permutations and combinations, but each one of these drugs has some major things that we look out for in terms of their side effect profile. Can you mention what you're on the lookout for?
Sure. I think the first thing I would say to any patient is you know your body. If you start on something and you're noticing that there are some differences or changes, I would rather you should always let your care team know. That being said, drugs like the IMiDs, when you first start them, can have a rash, typically on either the head or their torso. It can lower the blood counts. The other thing to look out for is blood clots. Some of our drugs, like pomalidomide and bortezomib, can cause neuropathy, so we always look out for numbness and tingling in the fingers and feet. Um, Many of our drugs can reactivate shingles, so most patients should be on shingles prophylaxis. If you're not, and you notice a rash that's got a lot of bumps on it, you should let us know. Carfilzomib has been associated with some cardiac issues. Much of this is either shortness of breath on exertion or some shortness of breath just in general. Those are some of the main side effects that we really look out for.
So Jeff, Josh has told us about the side effects. What are you looking out for in terms of that the patient is responding, that they're meeting the goals that you set out for, and that you don't need to change treatment?
Um, I guess if you're asking how do we monitor the response, is that the
Correct.
question?
Yeah,
Right.
correct.
So most patients have some blood or urine marker that we can follow. Um, Most commonly an M protein, which is some sort of abnormal antibody protein in their blood, usually IgG or IgA. Um, and we can track that as a surrogate marker of what's likely to be happening in their bone marrow, right? We don't have to count plasma cells to know that someone's responding. We can just track the product of those plasma cells, which is the M protein. Some patients, about 20% of patients, only have what we call light chain myeloma, and you can historically we would follow the light chains in the urine, but now we have a free light chain assay that's commonly used. Some patients only have a measurable light chain using that test. Some people have both an M protein and a light chain, and you can use both of those as markers of disease response and disease progression. Um, it's also, as I mentioned before, imaging is also an important part of disease monitoring. And speaking to what Josh said, especially as we get further down the road in a multiply relapsed patient, sometimes the blood and urine markers become less valuable, and and sort of the disease markers that we've been following sort of dissociate from what's actually happening with the disease. They become uncoupled, and so that's called either a non-secretory or oligosecretory progression. And so, in terms of listening to your body, progressive, uh, back pain or other bony pain, even if your numbers look okay, are always something to bring to the attention of your myeloma specialist, because sometimes we're surprised by skeletal progression, even though the markers look okay in the blood. And once we've established that that kind of thing can happen in a patient, skeletal imaging becomes a regular and routine part of disease monitoring, not just driven by symptoms, but it has to be actually just like built into the tracking schedule, the way we do blood tests in a way.
So one of the things you didn't talk about is the bone marrow biopsy. Do you do that at any time in monitoring?
So the short, not very often traditionally, because we have these good markers that we can use in the blood to know what's going on. We've right now, in the last several years, there has been some super sensitive testing that's become available called minimal residual disease testing. Um, and that requires a bone marrow sample, and it looks for like the needle in the haystack, like one residual myeloma cell out of every million cells in your bone marrow, sort of disease level. And we know in myeloma, like in other blood cancers, the deeper the suppression of the disease, the better the outcome. And so there's this interest in becoming MRD negative, right? We know it's a good thing, and when 10 years ago, I would have a patient whose blood markers would disappear, and I'd say, well, to confirm you're in remission, we need to do a bone marrow biopsy. And they'd say, does it matter? And I'd say, not really, because I don't need a bone marrow biopsy to know you've responded well to therapy. And they'd say, okay, I don't want a bone marrow biopsy. And now I have patients coming into my clinic saying, when am I having my bone marrow biopsy? I want to know if I'm MRD negative. So I would say I'm doing more bone marrow biopsies now than I did 5 years ago, and it's because knowledge of this testing and what the results mean has gotten traction in the myeloma community. It means our patients are paying attention to developments in the field. So I don't view it as a negative thing. Um, but I mean, that's the main reason I do bone marrow biopsies to track disease. The only other scenario, again, it's kind of goes back to that, something's going on, blood counts are dropping, new bone lesions have developed, something has happened, but the markers haven't changed, and occasionally I need a marrow just to figure out, what's actually happening with a person's disease. But that's actually not a very common reason to do a bone marrow. Usually you can tell from other clinical parameters.
Once again, I encourage the audience, if they have questions, to put it in the Q&A box, and we'll have our panelists discuss them. So, Josh, a topic has been brought up, MRD. So, what is your views on, is MRD ready for prime time? It's an assay. We know that people who are MRD negative do better than those who are MRD positive after a period of treatment. But how do you use it in decision making?
So I will preface this by saying, first of all, I think, Jeff brought this up expertly about the highly variable nature of this. I will admit that if Jeff Wolf is on one end of the MRD spectrum, I am on the exact opposite end. I am not the big. So MRD is a great tool. And I think the one thing that we've shown with MRD is if you take two identical groups of patients and then you treat them identically, and group 1 is MRD negative and group 2 is not, and you take average remissions, the negative ones will do better. But there's a lot more to the story. And, you can have patients that are MRD negative, but have disease outside the bone marrow, and those patients do worse. You can have people that never get to MRD negative, and there's some brilliant work being done by Bruno Paiva and others showing that you can have still measurable disease, but it kind of just sits there like an MGUS and never grows. And the MRD, the other thing is this is a zero line that gets better with our technology. You go back 50 years ago, the negative line was here. This is just an arbitrary negative line, and it will get better over time. So to me, if I've given you induction therapy and your scans are negative and your M spike is 0, I personally don't use MRD at that point because I don't care if we find 1% or 3% or no percent. Myeloma can be variable in the marrow, and it's not the end all be all. The one area where I highly incorporate it, though, in all honesty, is I think the notion of transplant or not has become a very hot topic. I still think that the data shows everyone, in general, you benefit from progression-free survival from transplant. But if I have patients that are younger and transplant eligible that say, I want a transplant, we'll do it. If you don't want it, we don't do it. If you're on the fence, I think it can be a nice piece of information that if you have standard risk disease and are MRD negative with induction, you probably don't benefit as much from the transplant. But if you still have residual disease, that's a tool that can help maybe extend outcomes.
So Jeff, you were shaking your head, so I guess you were in agreement. How do you use this assay when your patients say, I want my MRD, and you do it? What do you do with the result?
Well, the first thing I do is before we even test the MRD is I tell them ahead of time that we may not know what to do with the results. Honestly, like I always try to clarify with the patient that if we're testing MRD, like why? Like what are we other than just having the reassurance of a negative test, are we going to do anything in response to either a positive or a negative test? And I try and decide that up front, to be honest, so that there's not a lot of hand wringing later. The other scenario, I think, where MRD sometimes is helpful. I think we have some data that also supports the idea, just like um, like the data Josh was citing about the relative benefit of transplants with regards to the like extended maintenance therapy. If you
Mhm.
have a standard risk patient who's been MRD negative for 6 or 12 months, and they're we don't it's not standard really to stop maintenance therapy that's working right now in the United States. But if you have somebody who is uh, sort of unenthusiastically slogging through their maintenance therapy and hoping to be able to come off of it and wants reassurance that it is okay to do that, um, a standard risk patient who's MRD negative on a couple of occasions might be a reasonable candidate to think about a pause from maintenance therapy, knowing that they're probably going to continue to do well for quite a period of time after the end of maintenance. So we sometimes use it that way. Patients with high risk disease, though, patients who had an early relapse or patients who have high risk cytogenetic or FISH findings, it's unclear that even extended, what we call sustained MRD negativity, it's unclear that that translates into being able to take them off of therapy. So I think it's a little bit less useful in that patient group.
So MRD, obviously, for those who may not be aware, is minimal residual disease, a technology that allows us to detect one cell abnormal in 100,000 or a million, whereas traditionally, when you look at and do a bone marrow biopsy, have a pathologist look at it, they can go down to a resolution of 1 in 100. So yes, that was I think a fairly extensive coverage of MRD. I think Josh, you mentioned in passing as you were discussing MRD that there could be relapses outside the bone marrow, these extramedullary relapses. So, what can you tell us about these? How are they different? What's an extramedullary relapse? What's a traditional bone marrow relapse?
So, I think this is something that Jeff really pointed on really well. And, the way I always think about it is you start off with a healthy plasma cell and it makes antibodies to fight infection. You mess it up a little bit, it becomes abnormal, but it doesn't do much harm. It's an MGUS. You mess it up more, it becomes myeloma. And now instead of making a healthy antibody protein, it makes a full antibody protein, but doesn't really do much. You mess it up more, and it just makes that light chain. It gets a little lazy like me and just wants to spit out a light chain. You can still measure it. But at the other end of the spectrum, you have what we call an anaplastic cancer. It's just cancer. It no longer resembles a myeloma cell, so it doesn't make a bad protein. It doesn't even make a light chain. It just grows, and it can grow anywhere. And if it starts growing outside the marrow, we call that extramedullary or outside the marrow. And this can be, exactly as Jeff pointed out, I think for our general myeloma patients, I do scans once a year as confirmatory or if there's trouble. But once you show that your disease is either only behaving in an extramedullary standpoint or there's any disconnect between the blood and the scans, these are things you have to do almost every 3 months for patients. And, if they're just there, we give our best therapy to shrink it. There are times where there's a lesion that's pressing on a nerve or the spinal cord or in an area where we may even need to incorporate radiation for that.
So, Jeff, I think before we go on to the next talk, one question would be, Joshua did talk a little bit about doing something to prevent infections, to prevent blood clots. One of the other major issues in myeloma clearly is the bones. So, what do you do in terms of preserving bone health for your patients?
Right. So most patients with active myeloma at the time they're diagnosed start on some kind of bone strengthener, usually zoledronic acid or denosumab, um, and that's typically given for some period during the induction part of their therapy. In my own practice, most of those patients who start those medications are on them monthly for the first 6 to 12 months. And then at that point, I make a decision about whether they need to continue them or not, and if they do need to continue them, and usually that's based on um, uh, mostly how's their myeloma behaving, right? If someone's myeloma is in a flat out remission, I'm more inclined to try and stop these agents. And if their myeloma is in less than a remission, I'm more inclined to continue it. Also, um, the severity of their bone disease, honestly, at the beginning, also may factor into that. Um, the reason to back down on the frequency or even take a break is because there's cumulative side effects of these medications, and so we used to use them. Patient who would start these, they'd start them monthly and they would just stay on them forever unless they had a side effect. But that strategy actually increases the likelihoods of having a side effect from the therapy. There are certain issues related to the effects of these meds on bone remodeling, some dental complications, and a risk for pathologic fractures. And so we try to, over time, use these agents when they actually need to be used, and not just use them indefinitely in everybody.
Josh, is your practice any different?
No, I think one of the things that Jeff brings up, which I completely agree with, which is never really talked about in any of the guidelines, is what's the extent of their bone disease. We treat it from the guidelines as a very Boolean, you have bone disease or you do not. But I very much share his point of view. If you have one or two spots of lytic bone disease and you're in remission after a year, I don't know how much you really need aggressive bisphosphonates. Unfortunately, we have patients that have extensive lytic bone disease who need quite a bit more. The other thing that I would mention about bone disease, and I love history of myeloma, you know, most patients are going to have some bone disease, and nowadays we're very good about figuring it out by using not just X-rays but CAT scans or MRIs. There are people that can manifest with myeloma bone disease without little holes. And we go back to the original Crab, the 1975 paper, and there's a little asterisk next to the B. And they said if you had more than 30% plasma cells in your marrow and osteoporosis for no other reason, that would count as your bone disease. So this is not someone who's 90 years old, smoked 90 packs a day, weighs 90 pounds and has osteoporosis. This is the younger patient who's got a lot of myeloma in them. The scans are negative, but they're osteoporotic. So this is a case where women are far better than men. But I think it's really important that if you have, especially a man who's not following with regular bone densities, who you diagnose with myeloma, and the scans are negative, I actually recommend getting a bone density because that may be the manifestation of their bone problems as general demineralization as opposed to little holes.
I would say a clue to that is if a patient's developed a compression fracture without obvious lytic bone disease elsewhere.
Hmm.
That could be an indicator that actually there's just bone demineralization. And those patients also benefit from bisphosphonates, although they might not need the bisphosphonates monthly the way
Yep.
a patient with more traditional myeloma bone disease does. And speaking of those fractures, the other thing that we can do to manage skeletal disease, I mean, there are cement augmentation procedures that you can do to immediately relieve the pain, and also provide some stabilization of the spine when a vertebral body has compressed or collapsed due to a bone lesion.
So just since you brought up something that patients complain of fairly often, the bone pain, and you talked about, in addition to drugs, doing this bone augmentation with the vertebroplasty, or some I think even can go and see a pain doctor and may benefit by some kind of nerve block. But what about a more common problem, neuropathy? So, Jeff, do you have that's some of the most vexing issues that patients face. So, how do you tell a patient who's got bad neuropathy? How are you going to help them?
Um, you know, uh, Bad neuropathy is a really hard symptom for patients. I mean, I would say that there's no, general standard for how to manage it. The best thing one can do is avoid it in the first place. So honestly, I would say that, neuropathy is one of the most common and time-consuming things we talk about during patient visits, because so many of the drugs we use can actually cause neuropathy. And it's important not to just use them, sort of blindly until someone has intolerable neuropathy. Like usually occasionally that's how it develops. It's like a 0 to 60 and they have terrible neuropathy that developed over the course of a cycle of therapy but usually not. Usually it's something that you have plenty of warning about and you have the opportunity to intervene by changing the dose or schedule of the medications that they're on, or even switching medications if necessary, and avoiding that intolerable neuropathy to begin with. Once someone has it, um, we have medications like gabapentin, um, uh, you know, Lyrica, Neurontin. We have several medications, older medications, amitriptyline. We have topical agents with like topical anesthetics in them, capsaicin, things like that. And then there are some supplements like alpha lipoic acid or L-carnitine that people use. Um, when for instance the prescription meds that I mentioned at the beginning, when we prescribe those, they're better at addressing what we call the positive symptoms of neuropathy. Nothing about neuropathy is positive, by the way, but the things that you're experiencing that you don't normally feel, like pins and needles, tingling, those the lightning bolt like type flashes in your fingers, like those kinds of symptoms tend to respond to these medications. But numbness, which we call negative feel, negative symptoms, numbness, inability to feel vibration, inability to sense the position of your toes and fingers and things like that, those symptoms really there is no good solution for. So we really try to avoid that in the first place.
So it seems like prevention is the best strategy. Any other words of wisdom, Josh, that you have?
Um, no words of wisdom. I mean, anything that we try, the other things that so I've had some luck with Cymbalta. I like nortriptyline. I think it's got a good side effect profile, though. I mean, a good tolerability, but it can interact with a bunch of things. Some people like Effexor, but the thing that Jeff brings up is the most important thing here. I mean, if you look at the Velcade data, the majority of this is going to be reversible, but reversible doesn't mean it all goes away. And we have patients that have been in remission forever, and the only thing I refill in them is Neurontin and oxycodone. So this is something where we try to really enforce early on, even if you just have it occasionally, please mention it. And I think patients don't want to mention it because they're afraid of dose reductions or dose holdings and then suboptimal responses. But I really would encourage anyone that, we have so many tools in our toolkit. There's no reason to push things to the nth degree at the risk of having lifelong neuropathy.
Thank you very much. So I guess we'll move on to the next talk, and this is going to be on navigating care for triple-class refractory multiple myeloma. And I'm going to turn it over to Dr. Jeffrey Zonder, Professor of Medicine at the Karmanos Cancer Institute at Wayne State University. Take it from here, Jeff.
Thank you. Next slide, please. So, so I'm tasked with talking about triple-class refractory myeloma. And I think it's when we talk about that, triple class refractory means refractory to at least one proteasome inhibitor, one immunomodulatory drug or IMiD, and one anti-CD38 antibody, like either daratumumab or isatuximab. And most of what I'm going to talk about in this lecture, it really is discussing agents that we typically use and that are currently approved for later lines of therapy. But as we heard about, the way we currently use drugs in these three classes that are on this screen, we tend to use them in cocktails, and it's entirely possible to be triple class refractory after first line therapy. Fortunately, that's uncommon. The response rates to something like DARA KRD or DARA KRD or DARA VRD. Like these are, you know, almost all patients respond. And when they become refractory to first line therapy, it's usually in the context of one or two drug maintenance. And so their disease becomes resistant to one drug, but not necessarily to all three or four drugs that they used as part of induction. Still, you know, when you follow a first line three or four drug cocktail of medications with a second line cocktail of three or four drugs in combination, by the time you're through second or at the latest third line of therapy, it is very common to be triple refractory and sometimes what we call even penta-refractory, which means two proteasome inhibitors, two immunomodulatory drugs, and an anti-CD38 antibody. So, for better or worse, triple refractory does not always mean late line therapy. It might mean even second or third line therapy. Next slide, please. We know that once you've become triple refractory, outcomes are poorer. This is some survival data from a study called the Mammoth study. And basically, what this shows us is that once patients are refractory to two or three drugs, there is a difference in their myeloma related survival going forward. And when they've become penta-refractory, even more so. The reason for this mostly, honestly, is because when patients, even the triple refractory patients, once you are refractory to one drug in a class of drugs, your likelihood of responding to another drug in that class of drugs, it's not zero, but it's less than if you're still sensitive to that class. Your myeloma is still sensitive to that class of drugs. Next slide. So the first, I would say, breakthrough platform of therapy that I want to talk about for patients who have become really triple or often penta-refractory is CAR T cell therapy. So I think many people have heard about CAR T cells. This is a type of immunotherapy, and these are genetically modified T cells from a patient where the cells are undergo a manufacturing process so that they express receptors that allow the immune cells to target myeloma cells when they normally would not be able to do so. The two currently approved CAR T cells in the United States for multiple myeloma target something on myeloma cells called B cell maturation antigen or BCMA. Once the cells have been modified, and then the number of them have been expanded, and they're sent back in a bag to the center where they were collected, and then they can be infused into a patient, and you know it's a living therapy. You know these cells can persist and continue to work in a person's body for an extended period of time after they've been reinfused. Right now, the CAR T cells that we use are the patient's own CAR T cells. If you can go to the next slide. You can this is sort of a typical timeline. You can see that we collect the immune cells at the beginning, and then the sort of the biggest bottleneck in the journey here is the 4 to 6 week manufacturing time that a patient has to wait for those cells to be modified in order for them to work and then be given back. That's one bottleneck. If you could just hit the button for me, please. The other bottleneck, in the last couple of years has actually been a waiting period to get to step one of this journey. And some patients were waiting 2 or 3 months just to hit the front door of a CAR T center because there was a limited capacity to do this manufacturing. And so we had this, it created a backlog at the beginning too. First of all, so manufacturing capacity has expanded pretty significantly, so that waiting list is generally getting shorter and shorter and shorter. And on the last slide, there was something mentioned at the end, is that there are newer technologies. One is off the shelf, real kind of donor CAR T cells, basically, that are modified in a way that they can be given to anybody, and so those can just be kept in waiting, and you don't. It basically does away with the manufacturing period because they've basically already been manufactured. And also, there are newer platforms where the manufacturing period has, been decreased from 4 to 6 weeks down to like 4 to 6 days. And so they're in the future that manufacturing period is going to be much shorter, and it's important because right now that 4 to 6 week period is a it's not just a bottleneck, but it is actually it's an off ramp for some people, because right now CAR T cells, as we'll see on the next slide, are approved for patients who've had at least 4 prior lines of therapy that have included the 3 classes of drugs that we mentioned earlier in the triple refractory slide. And that's a situation where it's often hard to control somebody's disease. And so if you have a 6 week waiting period and you're trying to keep the lid on their myeloma and they're refractory to 3 or 4 or 5 drugs, some patients' disease cannot be controlled during that time, and they end up becoming too ill from their myeloma to actually proceed with CAR T cell. So the one strategy for this is shortening that manufacturing period so we don't have to work as hard to keep control of the disease. The next is going to be moving this CAR T therapy forward and using it earlier. We'll talk about that a little bit more in a few minutes. Next slide. These are the 2 CAR T therapies that are approved. One is idacabtagene viclucil, which is called Abecma, and one is called ciltacabtagene autoleucel, that's called Carvykti. They're dosed a little bit differently, but what we're seeing in that middle column is basically the number of cells that are needed to be reinfused into the patient. And then the indication for each of these is basically identical after 4 or more prior lines of therapy that have included those 3 classes of drug that we mentioned before. Next slide. So just to compare, it's a common question. Many patients who get are being referred for CAR T cells are being sent back to the same doctors who did their autologous stem cell transplant previously, and they say, well, is this the same thing? Because you're collecting cells from me again and then giving them back to me again. There are some differences. We are collecting cells. The cells are different. With CAR T, we're collecting immune cells, T cells. In autologous stem cell transplant, we're collecting stem cells. The stem cells don't get modified, but the T cells absolutely need to be modified. That's the manufacturing purpose, right? And the side effects are different, and also the chemotherapy that's used is different also. If you could hit the next button, please. We do use chemo in both cases. In the case of autologous stem cell transplant, the chemo, it's a very high dose of melphalan. That's the treatment. The stem cells are actually a rescue because of the collateral damage that high dose of chemo does to your bone marrow. In the case of CAR T cells, the chemo that we use is a different and in many ways milder form of chemotherapy that mostly creates what we call immune space. It basically is an immunosuppressive chemotherapy that allows these CAR T cells to engraft and expand and do their job. So it's the chemo's prep, but in this case, the cells are the therapy, not the rescue. The cells are the therapy. With autologous stem cell transplant, the chemo is the therapy. Next slide. So these are the reason this therapy, CAR T cell, has the hype that it does in myeloma is because even in patients who've had 4 or more prior lines of therapy, you can see here the response rates for patients treated with either Abecma or Carvykti are 73% in the case of Abecma and almost 97% in the case of Carvykti. And most of these responses are deep responses, what we call very good partial responses or better. If you could hit the button for me. This is in comparison to other single agent drugs in this same setting. Many of the drugs that we heard Dr. Richter talk about before, these were originally tested as single agent drugs or together in combination with dexamethasone in this same sort of 4 or more prior lines of therapy space. And when you go down the list of, carfilzomib, daratumumab, isatuximab, pomalidomide, selinexor, all of these drugs, they're all important drugs in the myeloma landscape, but as single agents after 4 lines of therapy, the response rates to these drugs are typically 20 to 30%. And usually the duration of those responses are somewhere between 3 and 6 months. So when you see these agents, single agents, CAR T cell therapy, with response rates above, that are at least twice and maybe 3 times as high as those other agents, and the average progression-free survival is typically somewhere between 1 and 2 years. It's a very different outcome than what we're used to with older agents in this space. Next slide. There are some toxicities specific to CAR T cells. The two that we're focusing on here on this slide are something called cytokine release, and another one is a form of neurotoxicity called ICANS events. Both of these tend to occur early within the first week to week and a half after getting the CAR T cells. Cytokine release is sort of like an immune inflammatory response. Typically, it can be managed with medications like tocilizumab or steroids. Sometimes things like oxygen or medications to support blood pressure are needed. Most cases are mild and can be managed without intensive care level management, but occasionally it can be quite severe. And when that happens, it may require more significant management. There is some data to suggest that this may be able to be prevented by using some medications in a prophylactic way. That's kind of an evolving question, and it's particularly the idea of prophylaxis is particularly common in the next class of meds I'm going to talk about, which are called bispecific antibodies. Neurotoxicity is a separate issue, although again, just based on the time frame, it's not as common as the cytokine release. And it often occurs in combination with cytokine release. And when patients start having neurologic side effects, particularly confusion, difficulty with speech, or like somnolence or sedation, those are symptoms that require early management. Generally jump on that quickly with steroids, and sometimes, if the symptoms are severe, anti-seizure medications to prevent seizures from occurring. We're going to talk more about low blood counts and infections when we talk about the next therapy, which is on the next slide. And these are called bispecific antibodies. Now you can see this picture, this structure that looks like a Y. I like to, actually, I describe it as a barbecue fork, right? Because it's like 2 prongs on it, and everybody knows what the business end of a barbecue fork is, right? It's the points on those tines. And in a normal antibody, those 2 points that bind to something usually bind to the same thing. So a usual antibody, like let's take the example of daratumumab or isatuximab, 2 different anti-CD38 antibodies. The business end on both points of those antibodies bind to something called CD38. Bispecific antibodies bind 2 different things. One of the prongs binds to something on the surface of the myeloma cell. So in this case, BCMA, although teclistamab and elranatamab are 2 BCMA targeting bispecifics. Linvoseltamab is an example, or REGN 5458, that's another example, BCMA targeting. The other prong binds CD3, which is a marker on immune cells. And so functionally what it does is it forms a bridge between the myeloma cells and immune cells, and then the immune cells become activated and can actually respond against the myeloma cells. This has the advantage of first, the target can on the myeloma cells can vary, and we see other examples, GPRC5D, which is the target on the myeloma cells for talquetamab, the other approved bispecific. And then FCRH5 is another potential target. That's the target for cevostamab listed on here. There are multiple different bispecifics in development, but what they all have in common, one arm of the antibody binds the myeloma cell, the other arm binds immune cells. What's nice about them, in addition to being able to target different targets in the myeloma cell, is that like any other of the drugs that Dr. Richter talked about, these can be right off the shelf. These can be prescribed right away without a manufacturing period. Think of these more like a drug product than a cellular product. Next slide. So here we see the data on teclistamab. Overall response rates, 63%, most of the responses, very good partial responses or better. Tends to be a little bit better when there's been less lines of prior therapy, but still, even in patients with high-risk cytogenetics or that extramedullary outside of the bone marrow myeloma, response rates are still about twice as high as what we would have expected with older agents. And we can see that the duration of responses here are in the range of 21 months for all patients who respond, and higher than that for patients who have a complete response. So again, higher response rates, much more durable responses. So I think of these as being more similar in a way to CAR T cells than to older therapies. They're kind of right in between in terms of the numbers. Next slide. Elranatamab, again, it's a second BCMA targeting bispecific, and honestly very similar efficacy data compared to teclistamab. 61% response rate. The majority of those responses are deep responses. And what we see here, progression-free survival is a little bit different than duration of response. So progression-free survival means you haven't died and your myeloma hasn't progressed. And what we can see here is that progression-free survival overall for all comers is still better than half of patients at a year. It's about half at 15 months. But the patients who achieve a complete response can have much more durable responses than that. And that has been our experience and the experience at other centers as well. Next slide. We have talquetamab. That's the third bispecific antibody on the market, and it targets something different than BCMA. This is response rates above 70%, and this is a subcutaneous medication, and there have been different doses and schedules explored, and basically a Q2-week schedule is usable. And we can see here again, median progression-free survival is a year on average, and again, just as we saw with the other antibody bispecifics, if you achieve a complete response, it's more likely to be durable. Next slide. In terms of expected toxicities, we see cytokine release like we do with CAR T cells, but the frequency of it is less. With CAR Ts, it tends to be really almost all patients, but with bispecifics, it tends to be about 2/3 of patients. Part of that, the platform's different. Also, we do a ramp up where we start with very low doses and work our way up to the full dose in the first week, and that may be part of the reason why the cytokine release is less. We also do see neurotoxicity. That's actually far lower than what we see with CAR T cells. Really just a few % of patients have what we call these ICANS events. I think the biggest issue with this therapy because it can be used for so long and because it's so effective at suppressing plasma cells and antibody production as we see infections. So patients often have low blood counts and low immunoglobulin levels while they're on these therapies. And it's usual to use some kind of infection prophylaxis. Most patients are on an antiviral like acyclovir to prevent shingles, and also on antibacterial to prevent certain types of pneumonia, what we used to call pneumocystis. So a lot of patients are on Bactrim. And then IVIG is a monthly infusion of antibodies that many of our patients are on to prevent infections when their IgG levels are extremely low. The other thing that I wanted to just point out that I sort of skipped over on this slide is what we call on-target off-tumor effects, right? The other side effects that I just mentioned are common to the platform of bispecifics and redirection of CD3 positive immune cells. On-target off-tumor effects are what the other target on the antibody, and is that target expressed on things other than plasma cells? So for instance, with talquetamab, we see skin rash, nail changes, and changes in taste that you don't get with the other two bispecifics because it has to do with the target. And so targeting BCMA doesn't result in those particular side effects. So it's specific for that target, and I would expect that any other bispecifics that had the same target as talquetamab probably would have this predictable side effect because it is technically on target even though it's not on the tumor cells. Next slide. So to conclude, several new classes of drugs are emerging for triple class refractory patients. I talked about CAR T cells and bispecifics. There are also trispecifics. There are also other classes of drugs. One's called CELMoDs, which is sort of a successor cousin of the IMiDs. We also have BCL2 inhibitors, which is useful particularly in myeloma patients that have a specific FISH abnormality of the T1114 translocation. We didn't really get to those. Those are all in development also. I pointed out that improvements in manufacturing capacity and speed are going to make CAR T cells more available. The other reality is that within the next 6 months, it's highly likely that they're going to be approved for use after 1 to 3 prior lines of therapy. And that issue of not being able to bridge patients successfully and keep the lid on their myeloma is going to be a much easier one to deal with. And we'll be able to get more patients safely to CAR T cells when we can use them a little bit earlier. They're also being studied up front, and the bispecific antibodies are also being studied up front after 1 to 3 prior lines of therapy and in combination with more standard myeloma drugs. So these last couple sentences, I can't overemphasize. I think that the conversations we're going to be having about first and second and third line therapy 5 years from now are going to be completely different ones than the ones that we had today. Thanks.
Thanks a lot, Jeff, for that excellent discussion again. So I think we're going to again ask the patients and caregivers and other attendees if they have questions to feel free to put them in the Q&A box. We have a question there. We'll get to it in a minute. But once again, as it said with Josh at the end of his talk, so we have an abundance of riches here. Jeff, how do we put it together? How do we decide which patient gets what?
Right now it is a little bit, it's kind of, unfortunately, it's a little bit biology, like disease biology driven at the moment, because we've had this log jam in terms of availability of CAR T cells. It's almost, we've been in a situation where we've been sort of forced to funnel patients with more aggressive disease onto bispecifics or other regimens rather than CAR T because they just can't sit around and wait. And so I think that's going to change. But right now, when we have a patient who is a good candidate, they haven't had a BCMA directed therapy. They're a good candidate for either bispecifics or CAR Ts. just based on the response rates that we've seen and the fact that CAR Ts are a one and done therapy, I think we tend to prefer CAR Ts if a patient can wait to get CAR Ts and if CAR T is available. But if it is not, then bispecifics, I think, are still a vastly superior alternative to the other regimens that we use in that 4+ prior lines of therapy setting.
So Josh, do you have a different algorithm?
No, I think that Jeff brings up all the great points. Then this was absolutely true, and I think one of the issues we're all gonna face is what happens potentially by April when these therapies do move up, because he's absolutely right. We're finally, with the bispecifics, have cleared out a lot of that, logjam that we had initially, but it's very possible we all go to bed on April 6th and there's 10,000 eligible patients for commercial CAR Ts in the United States, and we wake up on April 7th and now there's 100,000 patients who are eligible. And although manufacturing is going to be ramped up, there's going to be a period of time in the middle of next year where not everyone is going to be able to get them. And this brings up a lot of questions of how do you appropriately bridge, because one of the things that Jeff brought up, which is completely true, is bridging is not always easy in the later lines. If you look at the CARTITUDE-4 data, which is going to probably lead to the approval of early use of CAR Ts, the people who got the CAR Ts in CARTITUDE-4 in 1 to 3 prior lines, the response rate was 99.7%. Out of 216 patients that got it, 215 responded. But if you look at the total group, the response rate's around 85%, because about 10 to 15% of people did not get to the CAR T. Earlier relapse is going to help this a little bit. Will it help it all the way? Hard to say.
Right. I think when we look at the CAR T data, there's a difference between the likelihood of responding once you are sitting, on a cellular therapy unit and the CAR Ts are infusing versus the likelihood of benefiting from that therapy the day that you're referred for CAR T, because there are hurdles to get over. And a lot of people don't even get to that point where they're sitting there getting their cells. And if you start, the success rate, the efficacy of the treatment overall varies a little bit based on when you actually start counting. So I know we're inclined to think about how well they work once they've been infused, but you have to think about what are the chances of them actually being infused. There is a hurdle there to get over.
So I guess we approached it as bispecifics or CAR T. What about bispecifics and CAR T? What can we do them both? So Jeff, what is your advice? Can we get a bispecific and then when it stops working, go to the CAR T, or go to CAR T, and if it stops working, go to bispecific?
So there's data about that, and I think the best way to summarize it succinctly is just like with every other therapy that we do, that when you've become resistant to a class of medications, your likelihood of responding to the next therapy, particularly if it has any similarity in its mechanism of action, is less. And so a general rule that we talk about with patients, and I'm curious to know how both of you talk about this with your patients, but the general rule we talk about is whatever number you think the response rate is with a particular agent, knock 20% off that number when you're using it after a different bispecific or after cellular therapy. When you're coming back to it, I tell them roughly knock about 20% off the response rate, and that's a reasonable expectation about your likelihood of responding. What do you guys say?
What do you say, Josh?
I think there's a lot. There's a lot of nuance to this. I think the decision to use one or the other really depends upon the kinetic of things. I think we tend to put a lot of people on bispecifics when the disease is advancing very quickly. In terms of one or the other, I think there's a few things that are not proven, but I think we have some evidence for. One is probably better to do CAR T before bispecific than bispecific before CAR T. In general, it's because if you're on a CAR T, you haven't affected that antigen for potentially a long amount of time, months, if not years, and your T cells may have had time to recover, as opposed to bispecific, which you tend to stay on, and then relapse. So because of that distance between getting the actual drug, it's probably better CAR T than bispecific, but that's not to say you can't do it the other way around. The other thing is I like to treat it like, we treat myeloma like a chess game. It makes us sound much smarter than we actually are. In reality, we're feeling around in the dark, but we'll pretend that it's a chess game. If I have someone whose disease is advancing quickly and I want to get them a CAR T, but I don't think their disease is going to behave long enough, and right now those CAR Ts target BCMA, I'm more likely to give them talquetamab targeting GPRC5D now and preserving BCMA for the next line.
So, yeah, I think that I would agree that those are the considerations that go through my mind as well. One of the questions asked Jeff is from the audience is, can you give CAR T after failure of a CAR T? Can you give it? Can you treat a patient who's had a CAR T, had a good response, and then needs another line of therapy down the road? Can you do the CAR T again?
The short answer is yes, you can do that. In terms of what you get out of that, I think sort of along the lines of what Josh was saying, if you fail to respond to CAR T therapy and then come right back with a second shot at CAR T therapy, that is not likely to be a very effective strategy. But there are patients at our center and others who've gotten a second dose of CAR T cells, hopefully after some long period from the first CAR T cells, and it is possible to benefit from second CAR T. I would say the general experience with that is on the whole, second CAR T doesn't have the same degree of efficacy as first CAR T, although certainly individual patients can benefit significantly.
Josh, anything to add to that?
No, I literally nothing to add. It's what he said is exactly what we believe in.
So I also understand, Josh, that actually there may be CAR Ts coming up to other targets that may offer a better, chance of working than giving a BCMA CAR T again. So what can you tell us about CAR Ts to other targets?
Sure. So, I think there's a lot of ways we're trying to improve CAR Ts. Jeff talked about one of the ones of, off-the-shelf CAR Ts or rapid manufacturing to reduce that time. The other is exactly like you say, other targets, and I group these into two categories. One is the, other targets, of which right now GPRC5D seems to be the most robust data in terms of another target for CAR T. What's nice about it is so far we don't seem to have the same dysgeusia, nail change, skin changes that we see with talquetamab. That being said, the GPRC5D CAR T does have a little bit of what we call cerebellar toxicity. So it's a different type of neurotoxicity than we see with the other CAR Ts. Some of this data published by Sham Malankati over at Sloan Kettering, very encouraging new data. And again, it may be nice if you have treatment with a BCMA bispecific to have a GPRC5D CAR T. The other thing that's really nice is there's some very nice data coming out about dual targeting CAR Ts. So something that targets BCMA and let's say CD19, with maybe the thought process being, and I don't know if you guys will think this is old hokum or real, is the notion of, the BCMA targets the main myeloma cell and maybe the CD19 gets that myeloma stem cell. So there's some interesting data with the dual targets. I don't know if you guys buy into that or not. I know there's some differing of opinions.
Certainly, I know that it's a little controversial topic. Any thing to add on that, Jeff?
No.
So one of the things, Jeff, that you mentioned about was the CRS and the neurological toxicity. And so how do you manage it? You mentioned that it is associated with fevers, drop in blood pressure, need for oxygen sometimes. So how do you go about making sure it doesn't get out of hand?
Well, there are ways to grade both of these sets of side effects, cytokine release and also the neurologic or ICANS events. Basically, for mild symptoms, you might be able to manage that with just simple supportive, care. Fluids, low flow oxygen, Tylenol, um, maybe steroids. But when the symptoms become more severe, you want to use medications to sort of shut down the cytokine storm that's happening. And so one of the slides mentioned tocilizumab. To do that, um, and basically, I think every institution probably has their own basic sort of um, you know, treatment guidelines. But as the symptoms become more severe, it's important to recognize when they're becoming severe and to use those medications to sort of shut down that cytokine cycle. Um, Occasionally, if the symptoms become much more severe, then patients may need, I mentioned, intensive care level management because they may need things like pressors, medications to support their blood pressure and fluids to sort of get through that event. So that fortunately, even though cytokine release is quite common, that severe level only happens in a few percent of patients. And so, um, our center and many other centers, CAR T therapy and bispecific therapy, which historically, traditionally, has been started or given as an inpatient in an inpatient setting, is moving towards outpatient management, as long as there are systems in place to monitor patients for the development of these symptoms.
So I'll just put this to Josh. Josh, as far as side effect management goes, your center has probably one of the largest experiences with talquetamab for the on-target, but side effects due to expression of GPRC5D and other tissues. So how do you try to minimize the toxicity of talquetamab, Josh?
So, the first thing I'll say is we have no magic sauce. I don't think anyone really knows. One of the things that's become interesting with the bispecifics is that I think we're all very tuned into the kind of classical chemo way of thinking where dose is directly tied to toxicity. We're all used to giving Revlimid at 25, and if your counts are low, you drop it to 10 or 15. With a lot of these agents, dropping the actual dose doesn't really do anything. Sometimes spacing out the dose instead of giving it weekly, giving it every other week or giving it monthly may help. But in terms of the dysgeusia and the skin changes, the skin changes are a little easier to deal with. Lachydrin, ammonium lactate, and some of the other emollients can really help the skin changes, but most of that is not as life altering as the dysgeusia. We're trying a number of things, and in fact, there's a study that is being launched, a multi-center study called the Talisman study, and Talisman is looking into a variety of different topical compounds to mitigate the oral tox, randomizing people to things like a dexamethasone-based oral wash or even clonazepam as a mitigating agent. Again, we don't really have a secret sauce yet. This is not exactly like GVH where steroids will fix everything. So it's a work in progress. Right now, it's exactly like Jeff described. It's supportive care, artificial saliva, dose holdings if need be, but not much else.
So also Jeff mentioned, Josh, that this concept of trying to give CAR T and bispecifics outpatient. So where do you at the moment, Josh, give your treatments for your bispecifics and your CAR Ts?
So right now, CAR Ts are inpatient. So patients get the lymphodepleting chemotherapy outpatient and then get admitted for the cells, stay in the hospital for 14 days, and then go home. Although we're exploring different options for patients who have already had their CRS and resolved from it, that they may be eligible for earlier discharge home with close follow-up. Right now, bispecifics are following a similar pattern. We're giving the first dose as an outpatient, then directly admitting them through step up and then sending them home. A number of institutions are looking at starting and maintaining them outpatient. We're working out the logistics because that requires a 24-hour center that's not an ER to administer supportive care, which we have, but we need to get up to speed. But we're more looking at this early discharge model where most patients will get some degree, even if it's low-grade CRS early on with bispecifics. And tocilizumab as a drug has an extremely long half-life. So once patients get CRS, get tocilizumab, and then their CRS resolves, the likelihood of them getting another event or getting another event that's anything more than a little fever is very low. So we're trying to attack it from the back end first, and then we'll work on the front end.
What about you, Jeff? You brought it up, the outpatient concept. So where are you in
So,
that?
so for, it's a little bit tricky with the bispecifics because, like I said, there's a ramp up, period with each of these. So there are multiple doses in the first week, and the doses are escalating. And so the way we're approaching it right now is we are putting patients in for like a 23-hour OBS period where we administer the dose and then we watch them overnight, but discharge them before the end of the day the next day. And there's 3 doses in the first week with teclistamab, for instance. And so patients are basically are overnight observed for three nights in the first week. Sort of like 3 nights and 6 days sort of observation. But it is busy, but it is providing real medical monitoring for the majority of the time during that first week. And we expect that we're going to have relatively few patients who go home and develop cytokine release symptoms at home in the short intervals between the times that they're actually being observed during that week.
So
So
Josh,
there's going to be a geographic sort of limit on this, right? Like if you're back and forth, it's outpatient, but it's I mean you have to be close enough to get back and forth multiple times. Other centers are going to be bringing patients in and just watching them all day in an outpatient setting without an overnight OBS, and then and then having a 24/7 on-call person available, to get them back in and be seen if needed, overnight. I mean, different centers are doing it differently.
So Josh, as regards your comment that we may wake up in April next year and find instead of 10,000, 100,000 people are eligible for CAR T. I guess that is because CAR Ts are likely to be approved for second line, third line, fourth line, whereas today they're only for fifth line patients. So when they do get approved, obviously there'll be some constraints in the system that we may not be able to give everybody a CAR T in second line. But do you think if you had the opportunity, would you give every patient who relapses once a CAR T?
No, I mean, I think that's a really great question. I think there's going to be a lot of factors that go into that. I think that the patients who have demonstrated functional high risk are going to move up, in my mind, a little bit earlier, because when you look at first relapse therapy, most patients do quite well with it. So if someone had their transplant, been in remission on maintenance for 8 years and is now relapsing, I'm not rushing to put them on a CAR T because the likelihood is their next therapy is going to provide a good amount of help. But the younger, fitter patients that are not doing as well with upfront therapy, we're going to push them higher on the list, and I think that has to factor in quite a bit.
So, anything to add to that, Jeff?
No, I think, the reality is, as one of the first things Josh said in his talk was that um, one of the main reasons patients are doing so much better now than they were when I was in training is because second and third line therapy is so much better than it used to be. I mean, first line therapy is also better, but we always used to get mileage out of first line therapy. It was just what would you do next, right? And right now we have regimens that second line therapy will often control disease for 2 to 3 years. Third line therapy will often control disease for a year or two. And so it's yeah, we I think that CAR T will become one of the therapies available. right? And I think it will be used heavily. It'll be interesting to see what happens with transplant. Especially since a lot of patients now are deferring transplant to second line of therapy. If you have transplant or CAR T as an option as second line therapy, how one picks between those, I think, is not entirely straightforward. So we will, we'll learn as we go.
What about taking it a step further and deciding between transplant and CAR T as your first line of therapy? Yeah.
Thanks for that. That's gonna be a very very difficult question. I will say, I think that we have um, first line therapy followed by transplant followed by maintenance therapy can control disease in the majority of patients for quite a long period of time, and uh, uh, cost may be an issue. Um, uh, you know. Uh, Side effects may be an issue. Um, I don't know. I think that's a challenging question. I'm not sure I have a good feel yet for how that's going to go. I'm going to I'm going to say um, that's a hard question. I don't know. What do you guys think about that?
Josh, what's
So,
your crystal ball saying?
so one of the things that we've seen with a lot of our drugs, and I'll take daratumumab as an example. You give daratumumab at fifth, sixth lines, you get 29% response rate. You stay in remission for 6 months. You move Dara up front and combine it in the right way, you get 100% response, and the duration of remission is enormous. If you look at CAR T, fifth line versus second line, so CARTITUDE 1 versus CARTITUDE 4, it's not night and day different. It's not much different. And my very naive understanding of this is that I think there's some people, regardless of whether or not you give them a CAR T up front or end of the road, will do absolutely amazing. And some people in the same situation that will not, unfortunately, not do as well. So, I'm not entirely convinced that it's going to beat it up front because I don't know how much better it will get. The other is that the bar that we have for upfront therapy is enormous. And this leads into the complexity of how you approve drugs from the FDA standpoint. You know, you can't use overall survival as a marker anymore because people live so long generally. Response rate, upfront response rate is 100%. Progression-free survival, Dara-Rev-Dex transplant ineligible is greater than 5 years. It's really hard to prove that something is better in an appropriate amount of time, and this involves the complexities of MRD and the FDA. But I think CAR T is great. I'm not entirely convinced it's going to be transformative up front, but I think what we really need is a risk adapted model where someone gets something like Dara RVD and transplant, and if they're MRD positive, maybe those people need a CAR T or a bispecific, and maybe those that don't get it, and risk stratification in there. And now I'm just rambling, so I'm gonna go back to you, Ravi.
No, thank you. I think that we're going to, in a minute, try to relaunch the poll that failed at the beginning before we end. But one question for you, Jeff, that is from the audience, is what is ahead for a translocation 1114 patient on venetoclax who's had good results? Seems like 3.5 years of good control. So I guess the question is, what is the future beyond venetoclax should this stop working? I think that's the question.
Well, I think the venetoclax as a drug uh, uh, for potential FDA approval in myeloma has had a couple of major setbacks with the results of some trials. Not that the drug is not useful in myeloma. We have tons of data to suggest that there's this one subset of patients with the T1114 translocation, and potentially some other patients, uh, perhaps some other patients can benefit from venetoclax therapy, either in combination with DEX or in combination with a proteasome inhibitor. There's also data combining it with other agents, including anti-CD38 antibodies. So it's a drug with some utility, but it also has side effects, including infectious complications that need to be managed carefully. I don't think the drug is going to end up being approved in myeloma. I think it's going to be one of several drugs like bendamustine that is sometimes used to treat myeloma in the right setting, but probably won't be approved. There are going to be there are other drugs that target BCL2 that are in development for patients with the 1114 translocation, and perhaps those break through and get approval. It would be great, in my opinion. I see a lot of patients with a disease related to multiple myeloma called amyloidosis, and that 1114 translocation is a lot more common, 3 times more common in amyloidosis. And so having a drug that's useful in that patient subset would be great. I don't think the drug is going to disappear, but I do think that it's going to be continued to be used off label.
And if it should stop working, I guess all the drugs that we talked about, bispecifics, CAR Ts, are all going to be options for such patients.
Right. There aren't other drugs that would be specifically predicted to be helpful in this patient subset compared to compared to patients with other translocations or anything like that. Then I think it just goes to then you're just choosing from amongst the general agents that are available for myeloma treatment.
Well, thank you. So before we end, we're just going to try to relaunch the poll. Let's see if we're more successful. If not, we'll bag it again. But Navya, do you want to go ahead and relaunch the poll quickly, the 5 questions before we... Okay, the question's up there now. Are you a patient, a caregiver, or other? Please vote. Guess, Navya, we can move on. Okay. Second is, how old are you? 40 to 50 years, 51 to 60 years, 61 to 70 years, 71 to 80, or above 80 years of age? Okay, next question. Third. Where are you from? Which part of the United States are you located in? The Northeast, the Southeast, the Midwest, or the West of the United States? Okay, the fourth one. What is the most useful resource for your cancer journey that we can, as an organization, help you with? Disease state education, access to experts, peer support, psychosocial support, or financial support? I guess there may be one more question, and then we will be able to end. So now, or is that okay? Last question. If you're a patient, what line of therapy are you on? First line, second line, third line, fourth line, or fifth line? That's the last question before we wrap up. Okay, so I think we should have captured it all. So I just want to now end the program by thanking our panelists who've taken time out from Saturday to help educate our patient population and caregivers on multiple myeloma. Thank you, Jeff. Thank you, Joshua, for doing this. It's highly appreciated. We also want to thank our sponsors. This has been made possible by an educational sponsorship by Sanofi. And we all, in the end, want to thank our attendees. And before you leave, you did just take the pre-meeting survey, but there was the post-meeting survey that you will be prompted to take as you sign out. So please do. That will help us see how we can improve our offerings. Thank you very much. And once again, thank you to our panelists and everybody. Thank you. Take care.